Hello, everyone. Thank you for joining our pharmacist panel presentation, Leveraging Quality Metrics to highlight the impact of ambulatory care pharmacy. This session will be offered as continuing education credit for both pharmacist and pharmacy technician learners. My name is Jennifer Foti. I'm an ambulatory pharmacy clinical coordinator with Aurora Healthcare, and I will be moderating this panelist presentation today. I would like to thank the Professional Resources Subcommittee of the PSW Ambulatory Care Advisory Committee for their support in building the framework of this presentation and bringing our panelist speakers together. The panelist speakers, myself, and the planners of this presentation do not have any relevant financial relationships to disclose. To introduce our presentation today, we have a short video clip that was developed to highlight how frontline ambulatory clinic pharmacists throughout the state of Wisconsin define ambulatory care pharmacy. This video helps demonstrate the importance of quality metrics to support the value of ambulatory pharmacy services.
How would I define ambulatory pharmacy? So to me, ambulatory care pharmacy is all about being an important and accessible part of the patient's healthcare team in the outpatient setting, really stressing that accessibility component. Oftentimes it's going to be a lot easier for a patient to meet with their ambulatory pharmacist than it is with their physician. So whether that's their retail pharmacist or local clinic pharmacist. And then these ambulatory pharmacists play a really important role in ensuring accuracy and safety of medication regimens to allow patients to meet their long-term health goals and manage their chronic conditions.
For me, ambulatory care pharmacy practice is top of license, non-dispensing practice, working in partnership with our medicine and nursing colleagues.
Ambulatory care pharmacy to me is kind of a sweet spot between your retail pharmacy, where you have that long-term patient connection and relationships, where I get to see patients multiple times and follow up with them on their life events and their medications. I also have the autonomy to make clinical decisions and work with the healthcare team. So I really like the combination of both the patient interaction and the clinical knowledge that I use.
Ambulatory pharmacy to me is providing ongoing and comprehensive care for patients of various chronic disease states. That might include lifestyle education, device teaching, navigating the cost and insurance coverage of products, as well as medication management.
After completion of this presentation, pharmacists and pharmacy technician learners will be able to define the Centers for Medicare and Medicaid Services, or CMS, and Healthcare Effectiveness Data and Information Set, or HEDIS, quality measures that are impactable by ambulatory pharmacists. They'll be able to explain different ways ambulatory pharmacist services can positively impact quality metrics, describe how quality metrics can be utilized to create, justify, and expand ambulatory care pharmacist services. And finally, compare and contrast quality metrics used in federally qualified health centers and health system ambulatory clinical practice. Throughout the presentation, there will be a number of acronyms and abbreviations that will be used. Please utilize this slide as a reference if needed. Today, I would like to welcome our three pharmacist panelist speakers from different ambulatory practice locations throughout Wisconsin to discuss their ambulatory clinic experience and the quality measures they use to demonstrate ambulatory clinic pharmacist impact on patient care. Today, we have Drea Maier, ambulatory pharmacy director from SSM Health, Francesca Johnson, ambulatory pharmacist from Progressive Community Health Centers, and Nicole Green, director of ambulatory pharmacy from Theta Care. First, I am pleased to introduce Dr. Drea Maier, the Director of Ambulatory Pharmacy for SSM Health's Wisconsin region. Drea received her Doctor of Pharmacy from the University of Wisconsin-Madison School of Pharmacy in 2007, and then completed a PGY1 pharmacy practice residency at Unity Point Health Meriter Hospital. She is dedicated to expanding and enhancing ambulatory pharmacy services to positively impact quality measures. To help set the stage, each speaker is going to provide an overview of their ambulatory pharmacy services being offered within their practice settings. First, we're going to start with Drea.
Thank you, Jen. I am excited to share with you all. We've been able to leverage our pharmacy quality measures to build our ambulatory pharmacy programs and expand them. At SSM Health, you can see on the left side of the screen, we have a variety of ambulatory pharmacy services that at this point are pretty advanced and ingrained. So our largest team is our primary care clinical pharmacist team embedded in those clinics, mainly a focus on chronic disease management. They work under broad collaborative practice agreements and do full medication management and individualized care for our patient population that needs that. And we have a variety of pharmacists. We have a large medical group population at SSM Health. So we have 3 medical groups that have been combined under SSM Health, one in Monroe Clinic area, a large group in the greater Madison area, which was Dean Clinics, and then a medical group in the Fond du Lac region as well. The basis of the growth of these programs and the focus on quality measures, which we'll be talking about today, is that we have been an integrated delivery system for quite a while. So in Dean Medical Group, we also have Dean Health Plan and Navitus as our pharmacy benefits manager. And so with that setup, we've been able to show the impact and financial impact that improving quality measures and care and preventative care for our patients has. And that has grown exponentially in SSM Health. And in 2022, we have officially become an accountable care organization, which Nicole will talk more about later. But over 80% of our patients in our primary care clinics are under some sort of alternative payment model. So their quality measures are very important. And we are actively growing our population health pharmacy team. Right now, we just have 1 pharmacist FTE that specifically focuses on medication adherence and statin measures, which we'll talk about moving forward. And then we have some large ambulatory services in their specialty areas as well, like anticoagulation and infectious disease as well. The growth of the program. Some of our programs kind of grew up independently and have all come under the umbrella of SSM Health. It's been exciting to share best practices across them and grow together in a larger system view. Monroe Clinic started in 2007, Dean's Group started in 2015, and Ignesians in 2020. And again, the expansion of FTEs in really all of those scenarios, at least in Dean and Fond du Lac, have been based off of justifications from improvements in quality and clinical outcomes. In the future for our programs, we are definitely actively looking at adding support staff and utilizing pharmacy technicians to the top of their licensure to help our teams, especially in the population health and quality realm. And then we are actively working on implementing some auto referrals for key populations in our alternative payment model contracts that need more chronic disease management instead of waiting for providers to refer the patients. And we're always looking to more easily track and automate our metrics and outcomes to demonstrate the value of the services.
Thank you for that overview, Drea. Our second speaker today is Dr. Francesca Johnson. Please join me in welcoming Francesca. Francesca received her Doctor of Pharmacy from Northeastern University in 2017. She completed a PGY1 pharmacy practice residency and a Master of Science in Education in 2019. Through her role as an ambulatory care pharmacist at Progressive Community Health Centers and an assistant clinical professor at Marquette University's Physician Assistant Program, Francesca is passionate about advancing pharmacy roles and promoting cultural humility. Francesca is going to provide us with a brief overview of the services being offered at the Progressive Community Health Centers.
Thank you for the introduction, Jen. I'm excited to be here today. So just a little background on Progressive Community Health Centers. We are a primary care patient-centered medical home and a federally qualified health center located in Milwaukee. We serve disadvantaged patients who are living in an urban area and are living significantly below the poverty level. So there's lots of complexities in the patients we serve. I implemented services in 2018 during my second year of the residency program, before Progressive had ever had or thought about having pharmacists on board. We started with collaborative practice agreements for ambulatory care pharmacists. You can see we have several different disease states here, but the primary health condition that we serve is diabetes. But once we have them referred for diabetes, we can also co-manage their other health conditions. We also have developed a comprehensive medication review and medication adherence protocol as part of our CPA, which helps us target quality measures, which we'll talk about a little bit more later, as well as we have our current resident who completed her first year at Progressive, where our residency program is, but has actually decided to stay on a second year with us to develop a mental health service, mainly focused on depression. We're continually growing, and the goal each year is to add on an additional health condition to target to really ensure we're best serving our patients. This slide identifies the timeline of how we've continued to grow. Now, our clinic is a lot smaller than the other health systems represented. So even though it doesn't seem like we have a lot of pharmacists FTE, it truly was exciting to be able to do this. We only service 8 or 9 primary care providers. So starting in 2018 with only 16 hours per week of CMM visits, and then increasing, you can see we've increased almost every year to an anticipated increase of 48 hours per week of clinical pharmacists, ambulatory care services. We're also developing that mental health management service. And in addition to that, we offer care management where we collaborate with several nurse care managers and other team members to really ensure that our patients who are hitting the hospital the most are having their medications optimized to prevent those hospitalizations. Our quality service started in fall of 2018, where we work with 2 health insurances to help improve the quality measures, as well as we can bill through Outcomes MTM for comprehensive med reviews. And then we also take a look at our quality measures each year and do prospective interventions for those who have failed the previous year. Lastly, we contribute to quality at our organization by offering various educational and support groups.
Thank you for the overview, Francesca. And for our third panelist speaker, I am pleased to introduce Nicole Green, Director of Ambulatory Pharmacy for ThedaCare. Nicole completed her pharmacy education at the University of Saskatchewan, Canada. Prior to her role as Director of Ambulatory Pharmacy, she practiced as a clinical coordinator in cardiology. Now, as Ambulatory Pharmacy Director for ThedaCare, she has spearheaded the strategic planning to embed pharmacists as providers and vital members of the primary care team of ambulatory care clinics. Nicole strives to advance the pharmacist role in team-based ambulatory care settings. Nicole is going to provide us with a brief overview of the ambulatory pharmacy services being provided at ThedaCare.
Thank you for having me. Really excited to share our story. And I think it's really interesting to look at the stories across the leadership team and the organizations here. Ours started off a bit uniquely, really. It was through an opioid stewardship initiative or a population health initiative that we really formalized our program in January of 2021. We were responding to the question of how will you improve opioid prescribing within our community? How will you do that? And it was really through the vision that we would have pharmacists embedded in family medicine call groups and internal medicine. As you can see, we did start small with myself as the director and then 3.2 FTE across 2 family medicine call groups. We quickly expanded in August of 2021 by responding to another ask, and that was, gosh, while you're at it, can you help us to maximize our performance with pharmacy measures within our ACO contracts? Through taking that on and really owning those initiatives, we were able to expand our team such that we had ambulatory pharmacists across all family medicine clinics throughout all of ThedaCare. So very exciting. And certainly some of those locations had more remote support versus in person, but really utilizing, as was pointed out earlier, pharmacy measure performance in our ACO contracts to expand our team. This year, we also expanded to incorporate partnership with our retail pharmacy team to utilize some savings that we could take advantage of for our employees and 340B initiatives. Through this, we were able to add a manager, 0.6 FTE pharmacist, and we are already discussing, of course, how we can further expand this in 2024. One exciting initiative that we were able to do as well this year, just very recently in place, we now have an ambulatory pharmacist with a dedicated focus in heart failure, thinking of those heart failure medication optimizations, reducing readmissions. We had an initial pilot with myself and a few team members where we established a team-based clinic in heart failure clinic within the cardiology department 1 day a week. And through some great outcomes there, we were able to formalize a 0.8 FTE for a heart failure dedicated position. Our future areas, we are at this moment looking at some more formalized role within our transitions of care space for those higher risk patients. As I mentioned, expanding within the employee health and 340B initiatives. And though diabetes is absolutely our number one reason for referral, we are now also looking at, should we more formalize that in terms of perhaps automatic referrals or things like that in terms of a strategic organizational initiative as it relates to diabetes management.
Thank you for the overview of Theta Care's ambulatory services, Nicole. To start our presentation today, let's begin with a pre-learning assessment question. What quality metrics are measured in the ambulatory care setting? A, clinical metrics, B, operational metrics, C, financial metrics, or D, all of the above? The questions that are going to be asked throughout the presentation today will address the important quality metrics that are used in different ambulatory clinic settings. As we begin our presentation today, it's important to be aware that you will be hearing about 3 different examples of ambulatory pharmacy practice. There is wide variation between ambulatory clinic settings and health systems. Key elements involved in determining quality measures and measurement programs include the associated earnings and quality of patient care that you're trying to improve. In other words, where should you focus your program in terms of need and return on investment? Method of aggregation, meaning payers or organizations, they're going to have different patient populations with different incentives and rules that need to be followed. How an organization receives incentives is crucial to ensure that you align with meaningful focus areas. And finally, normalizing risk for your patient population for expected incidence of outcomes. From a global perspective, there are many quality measures and programs available, but it's important to know that there's not one single measure that's the same across all programs. The goal of having quality measures in place helps to improve patient care, harmonize your healthcare outcomes by bringing patient safety, patient family engagement, care coordination, and access to affordable healthcare together by reducing reporting burden, and finally, identifying opportunities for improvement. The quality metrics that are discussed today are important as we prepare for implementation of provider status. The use of clinical, financial, and operational metrics helps to demonstrate the value of ambulatory pharmacists as an integral member of the healthcare team and to be recognized as a provider. Our first question is going to be directed to Drea. How are Centers for Medicare and Medicaid, or CMS, and Healthcare Effectiveness Data and Information Set, or HEDIS, quality measures used in your clinic settings?
Thanks, Jen. So for those that aren't familiar, we're going to give you just a little bit of background on the measures and then let you know how we use them. So Healthcare Effectiveness Data and Information Set, HEDIS, is a tool that measures performance on many different dimensions. So certainly not just pharmacy or medication related quality measures, but a whole variety of measures. What's important to note is that it's very ubiquitous measures. So over 90% of our health plans report some sort of quality results in relation to HEDIS. So it is important for pharmacy and pharmacy leadership to be aware and see where we are able to show an impact and where our health systems and our programs need help, and use that as an opportunity to show what pharmacists can do in those different areas. If you go to the next slide, Jen, I believe we have these are just some examples. And as Jen mentioned, quality measures are not the same everywhere, and they do change regularly, at least every year, typically. Some obviously stay the same, but it is important to kind of stay on top of that. But this demonstrates a variety of areas within these HEDIS quality measures that pharmacists can absolutely have an impact. Nicole already mentioned, for example, the opioid management and use of opioids at high dosages, and how our pharmacy teams can certainly impact that. Our programs in primary care at SSM Health absolutely provide comprehensive diabetes care services as kind of our overarching population, or our largest population of chronic disease management patients we have currently, making huge impacts there. We've shown over a 2% average decrease in A1C from the time of pharmacist referral to the time that they go back to usual standard of practice, and that's over standard of care, including CDC, diabetes educators and dietitians, et cetera. So we've been able to demonstrate big impacts on those quality measures. Just as an example, other things, statins we'll talk about, but really a whole variety of different areas. So again, it depends on what your patients and your programs and health systems need help in or need improvement in, and really where you can target those pharmacist services. But there's a lot of different opportunities out there. This is another, just kind of threw this in here more for information, but again, variety of different measures that pharmacists can absolutely impact, including comprehensive medication reviews, which is a huge area of opportunity as well. This it's a quote unquote MIPS is what you'll hear it called, but there's a merit-based incentive payment system. This is available as a different set of quality measures, and Francesca can chime in on this one a little bit more because they use them in her FQHC population, but it does provide additional incentive payment for additional measures that pharmacists can impact.
Thank you for the overview, Drea, on the CMS and the HEDIS quality measures and how they're used within your health system. Our second question is going to be directed to all of our panelist speakers. How do you measure star ratings within your clinic setting?
I will just give a brief overview and then everyone can chime in, but star ratings, to tag off of kind of the larger sets of quality measures we just talked about, star ratings are probably the most specific. Medicare Part D star ratings were created in CMF's 5-star rating program. And those are very pharmacy specific. One key point to know about star ratings overall is that there's a comprehensive star rating for each health plan with under Medicare or CMS, and pharmacy measures tie up into that overarching comprehensive star rating, depending on exactly how your program's laid out. It can be anywhere from maybe 12% of that overall star rating to potentially up to 30 to 40% impact on various star ratings that your pharmacist may have. The overall star rating is very much tied to financial performance for your health system. So just make sure that you're tying all those ends together, but it's absolutely mutually beneficial for both the health plan and the health system to perform well and have a high star rating. So make sure that you're leveraging relationships with health plans and payers as well. I can talk through this and then let Francesca explain the details, but just to give you a little more insight into the specific Part D pharmacy star ratings. They are listed on the left side of the screen. Those tend to be medication adherence focused for diabetes, hypertension, and cholesterol or statin medications. Important things to note, and then, sorry, the technical Part D ratings also include the statin use in persons with diabetes. But important things to note, each different measure has different weighting. So again, it ties up to a comprehensive star rating measure, but triple weighted or measures are going to have a larger impact on that overall comprehensive rating. So it really just, again, depends where your system's at and what the priorities are and focus is, but medication adherence definitely is an important component. And I guess another piece of advice would be to not limit yourself to saying that you're only impacting those 10, 11 points or whatever pharmacy specific, because improving medication adherence improves hypertension control, diabetes control. It improves numerous other health outcomes for the patient. So you may have to present it as a range, but don't limit yourself to saying you're only impacting those measures. And other things to point out, the threshold or the target of how to reach a 5-star rating versus a 4-star versus a 3-star is a moving target, which I'm sure everyone else on this panel can speak to. They typically, the cut points we call them, they typically increase each year. So everyone is pushing each other, I guess, to get better and better at these quality ratings.
For the overview, I'll also talk specifically about what this meant for Progressive. So this is our star ratings for one of our MIPs, actually, our merit-based incentive payment Part D plans, where we've entered a value-based contract with them. So within that contract, there's different parameters. Some parameters you might find are, if you improve from one year to the next, you get a certain bonus payment. If you reach a certain threshold, you get a certain bonus payment. And so using this type of contract, our goal was really just to, from 2018, I started about halfway through the year, so we kind of count that as a wash year. But we wanted to see where we were in 2018 and can we get above that 3? Because once you get above that 3 into that 4 level is where more of these incentives kick in. And so the goal was really just to improve to at least a 4 and continue to push forward. As you can see, it ebbs and flows with how well we do, also based off that moving percentage threshold target. But just looking at this one contract that only covers about 50 to 60 members each year, this one contract was able to pay for at least 30% of my salary, even though I only used about 4 hours per week dedicated to this contract. So leveraging different value-based contracts can really help support the additional pharmacist's involvement, just because it can be a pretty large payout comparatively for a small amount of time. Different contracts may have different levels of support too, but I can say one of the contracts I work with actually sends me member data every week to tell me like who's falling past due on their medications. And so partnering with those insurance companies when they have additional support can also be helpful. And then just to kind of sum up, these numbers are only the ones that we found pharmacists typically impact, but there's other ones as well, not listed here. For example, like diagnostic screenings, labs, etc., that we also impact. And so when we extrapolated the data, these measures were accounted for about 40% of the other star measures we looked at. And so that's how we were able to extrapolate of our entire reimbursement quality contract we received back at the end of the year for our success. We contributed 40% of that to the work me and the care managers do related to controlling diabetes and making sure medication adherence is looking good.
Thank you, Francesca. That's very informative. Nicole, do you have any insight from the star ratings that are being used from Theta Care?
Yeah, I think a lot of it really echoes what we've heard. Certainly something that if you're not looking into for your organization, I would definitely urge you, because it's going to have a strong ability to influence support to either create or expand. I love the points that Drea made as well, as don't sell yourself short, because there is a carryover effect as you look at adherence, for example, and how that improves, diabetes control and hypertension control and so on. So I think I'll just add that for now. And I think I have a slide later that speaks to ours as well.
Perfect. Thank you. You can definitely see that there's a lot of value behind tracking the star ratings from the patient care perspective and from revenue generation as well. Okay, this brings us to our first learning assessment question. What services can pharmacists use to impact ambulatory care quality metrics? A, chronic disease management. B, comprehensive medication reviews. C, statin initiation and optimization. Or D, all of the above. The correct answer is D, all of the above. Chronic disease management, comprehensive medication reviews or CMRs, and statin initiation and optimization are all services used within ambulatory care pharmacy practice to make an impact on quality metrics. Referring back to the table presented by Drea, each of these ambulatory pharmacy services are being evaluated through the HEDIS and the STAR quality measures. Our next question is directed toward Francesca. How do you use Uniform Data System or UDS measures in a federally qualified health center?
So when I entered the FQHC world, I quickly learned there's additional alphabet soup to learn. So for those of you in this space, we will report to the UDS or Uniform Data System, which is really just an annual reporting system that provides standardized information about performance and operation of health centers delivering services to underserved communities and vulnerable populations. The UDS data is used to evaluate and improve health center performance, ensure that health centers are in compliance with legislative mandates, and then also to help identify trends in health centers' impact on expanding healthcare access, addressing disparities, improving quality, and reducing healthcare costs. So the UDS is funded by HRSA, or the Health Resources and Service Administration. And what these HRSA programs do are, first we'll focus, for FQHC, they're helping people who are underserved or disadvantaged in need of high quality primary care. But HRSA also funds several other types of programs that you might be involved with as pharmacists. So for example, they fund programs that help support people living with HIV and AIDS, programs that help pregnant women and mothers, as well as to help with the training and distribution of healthcare providers into areas of high need, providing training and scholarship programs to incentivize providers to go into those areas. And then lastly, HRSA helps to fund healthcare facilities that meet certain requirements. And so it really is important in FQHC or other areas that receive HRSA funding to be able to report and do well with the quality measures provided each year. So each year they change a little bit. These are the 2023 measures, but you can see there's 3 different buckets. There's screening and preventative, maternal care and children's health, and disease management. Naturally, pharmacists contribute most often to the disease management. So you can see that statin therapy for prevention and treatment of cardiovascular disease is a huge one across all boards. Antiplatelet therapy for ischemic vascular disease, HIV linkage to care, and depression remission at 12 months. So that depression remission is a newer measure, and you can kind of see why my resident is deciding to work on a depression service so that we can help target this specific measure. And then with the other things we do, looking at statin and aspirin every year at the end of the year when we get our report of who failed that statin or aspirin measure. My team goes ahead and reviews the charts and then will initiate statin or aspirin if therapeutically appropriate to help make sure those patients don't fail the next year. While the bulk of what we do is in disease management, I do always like to advocate, we're taking care of the whole person. And so we truly can impact these other measures too. As you're having a visit with patients, it's also important to take a look at their screening and preventative care. And although some of the things we can do ourselves, such as tobacco use screening and cessation intervention, other things might require a referral from the primary care provider. So we still take a look at that, and then we'll help be that intermediate person to ask the primary care provider to order those screenings. And we'll also talk to the patients about the importance of getting those screenings. So that's another way we can impact. And then lastly, the maternal care and children's health. I think a big area that pharmacists can start to contribute to, we don't in my current site yet, but I think in many other sites, definitely that childhood immunization, as well as assessing nutrition status, like as we progress through weight loss, I think different weight loss services, I think that pharmacists could definitely potentially impact those measures as well. This is just an example of recent diabetes measures. So HRSA, they are a little less strict with their diabetes control. They look at rates of diabetes control, meaning an A1C of over 9% or not having an A1C test within that year. So we want a lower number is better here. And we were recently awarded in 2022 for advancing our quality by going from our higher levels of uncontrolled to our lower levels of only 22% of our patients with diabetes are considered uncontrolled or haven't had a test yet. So what I think is really cool about HRSA and UDS is that they will publicize information and award different awards based off of how health centers are performing. On the next slide, I think this is really powerful for pharmacists, but also for patients and community members. UDS publishes every single health center's performance each year on their quality measures. So this is open to the public. This is something you can look at as a pharmacist at a health center, or maybe someone who wants to get into the health center realm to see areas that the health centers are doing well or maybe not so well. So you can see here, we've been doing well in statin therapy, we've been doing well in diabetes management. Areas of potential additional control would be that aspirin or antiplatelet therapy or controlling high blood pressure. So this is a really fast and easy way for me to look at the data and see areas I can impact. And in fact, this is how I started the practice at Progressive, was by looking up this data. And when I pitched myself to be a resident there and start pharmacy services, I had pitched that I saw they had needed some improvement at the time at diabetes and hypertension. So I think this is a really helpful tool for pharmacists.
Francesca, thank you so much for the overview of UDS measures and how you're using those at Progressive Community Health Centers. Okay, for our second learning assessment question, what uniform data system or UDS quality metrics could be measured in a federally qualified health center ambulatory care setting? A, % of patients with diabetes mellitus and A1C less than 9. B, % of patients with hypertension and blood pressure less than 140/90. C, % of patients 12 years and older screened for depression. Or D, all of the above. The correct answer is D, all of the above. Let's refer back to the chronic disease management UDS tables presented by Francesca. As you can see, each of these measures are UDS metrics that are used within an FQHC clinic setting. And as Francesca noted, monitoring and tracking the control of blood pressure and A1C is a very important measure to be following. And on this On this table, you can also see screening for tobacco and for depression is also very important measures to be following. Our next question is directed to Nicole. How are quality metrics used in ambulatory care clinics embedded within an accountable care organization or an ACO?
So setting the table for ACO discussion again. So an ACO is a group of physicians, hospitals, and other healthcare providers who come together voluntarily to coordinate high quality care for their Medicare patients. This can result in shared savings programs as incentives. And as earlier mentioned, it is really mutually beneficial. You do want to be sure that as you learn and refine your work and your strategies, that you do understand if there are differences amongst your payer contracts. You don't want to necessarily assume that one contract and the potential earnings are the same going into the other contract. And it's really important as we think about that to look at the different types of measures of quality in healthcare. So starting off first at the very beginning, your structure measure is really that characteristic of the individual healthcare provider, the organization, or the facility. A simple example is really having access to an electronic medical health record. A process measure is delivery of the specific clinical service. As an example here, percentage of individuals who receive a specific medication after a heart attack. We've certainly talked about a few of those in the earlier slides. The outcome, of course, is our ultimate goal. If we don't affect the outcome, we really need to go back and go, okay, how is our structure and how is our process really helping us? The example here, again, what we're really trying to affect and what's really meaningful, decreasing 30-day readmission rate for individuals after a heart attack. Of course, readmission is something that we can absolutely affect and should consider in one of our strategic approaches. A little bit repetitive, but I'll take a bit of a different spin on this. So you've heard about the various pharmacy measures or medication measures, all those different things within the ACO contracts. One thing that I do want you to keep in mind, again, there are so many different measures. We cannot divide ourselves infinitely to be able to affect all of these. So something you might want to do is look at the weighting of the outcome, meaning measures are weighted differently in terms of impact towards driving your ultimate star rating. And remember, your star rating correlates to earnings, okay? So if you look over at the table here, you've got breast cancer screening, colorectal cancer screening, both weighted as 1. As you look at hemoglobin A1C and the 3 medication adherence measures, in this case, they are triple weighted. So focusing in on one of those measures gets you 3-fold bang for your buck. Doesn't mean you necessarily ignore the others, but maybe you determine where you need to prioritize your efforts, particularly if you're just starting out or if you have limited resources. And some of the other ones you could think are maybe others are doing some of that work as well. But of course, as you can see, this does include preventative screenings, clinical outcomes. The piece that I want to talk about a little bit here is what's important too, is the shift recently, which I suspect will continue to shift, is the weight difference as it relates to patient experience. Patient experience is becoming more and more important in terms of providing that high quality care, which really speaks to is it meaningful to the patient? Is it meeting their needs? And so that's something that you want to think about as well. And I strongly believe, of course, that ambulatory pharmacists can have a very positive approach in this. I know our organization, as well as I've heard from our other leaders today, we take that comprehensive approach, meaning I'm going to look at all of their medications, but gosh, while I'm at it, I'm going to look at some other things too. A patient will often come to you with questions, struggles on coordinating care, and we can help with all of those things, which translates to a better patient experience.
Thank you, Nicole, for providing an overview on how quality metrics are being used in an accountable care organization. For our third learning assessment question, which of the following statements is true regarding metrics for an ambulatory pharmacist program? A, A1C reductions with an ambulatory pharmacist results in direct revenue. B, reductions in readmissions are not a good focus area for a pharmacist embedded in family medicine as it relates to hospitalizations. C, patient panel sizes should be mirrored exactly off of a primary care provider patient panel. Or D, top performance in ACO pharmacy measures can be used to support a program where the ambulatory pharmacist drives improvement in this area. The correct answer is D, top performance in ACO pharmacy measures can be used to support a program where the ambulatory pharmacist drives improvement in this area. ACO pharmacy performance brings in significant revenue that can help support your program. And all of the other options are incorrect. A1C reductions don't necessarily bring in direct revenue. Reductions in readmissions are a strong reason that you should focus your resources if you have supporting literature. And finally, ambulatory pharmacist practice is much different from a typical provider practice with a much smaller patient panel size. Our next question is directed to all of our panelist speakers. What clinical, financial, and operational quality metrics do you measure in your clinic setting? Let's start with Drea from SSM.
At SSM, we measure a variety of outcomes and metrics as listed on the screen. I am going to hop around and just try to provide some insight into some of them. I am going to start actually on the right side. Operational resources or operational metrics, excuse me, are the easiest things for us to track. To be honest, they're not always easy, but they're easier than some of the clinical and financial outcomes. We, using our EHR and other analytics tools, are able to fairly easily pull productivity measures, right? So volume of patients on our panels, number of referrals they're getting from providers, how quickly some of our administration likes to see how engaged our patient population is when a referral gets scheduled with them, the schedule fill rate of our patients, our no-show rates, cancellation rates. And I'm obviously proud to say that our no-show rates, cancellation rates are very, very low. Some other service lines, that's not the case. So we have very good patient engagement, but those types of things are relatively easy for us to track and are important to demonstrate the value and impact you're having on the larger population. Visit breakdown is really just the telehealth versus in-person. Our pharmacists are embedded mainly in the family medicine and internal medicine practices. And so it's really patient preference at this point, whether they would prefer a telehealth visit versus a in-person visit. So it's interesting to kind of track that breakdown. But what I really wanted to point out on the operational resources is tagging off of what Nicole just mentioned about patient experience and how that's very important. It is very important. It touches a variety of measures. And we also believe that adding a pharmacist to particularly these complex patients with a lot of barriers, care teams, has a very positive impact on their experience. And they often provide us that verbal discussion and stating that is true. But one unfortunate thing is without provider status, we don't have the same ability as other providers do to have kind of the standard, whether you use Qualtrics or other programs. CMS has some standard patient satisfaction and experience surveys that go out. Unfortunately, we've tried for years, but we can't quite get that to happen. But we have recently, we're excited about it. So I'm going to share, we recently were able to work with Qualtrics, which happens to be the current vendor we use for our patient experience surveys across SSM. Able to partner with them, make a specific survey for our clinical pharmacists. The only kind of difference or downside, so we do get it tracked kind of in a comprehensive way and outcome measures sent to us in a similar format as providers. The only major difference and downside is that it doesn't get pushed to every patient that our pharmacist sees. The patient has to choose to scan the QR code or go to the website to fill out the survey. So the N is smaller for sure, but we're excited to be able to report those patient satisfaction results because they are very high. And I think given what Nicole mentioned about patient experience, that is an important thing to be able to capture and measure and speak to with some hard data. As far as clinical outcomes, I think that is probably the most important thing we can measure, but also probably the most challenging. But we do measure somewhat manually. We recently were able to do it a lot more automatically, but measure change in A1C in our patient population. We chose not to do it exactly as providers do, where they just look at their whole panel of patients and look at their A1C control. The problem is we're only really referred and manage that smaller panel of more high-risk patients who are uncontrolled typically when they're referred to us. So it's not really fair to assess the overarching A1C of patients on a pharmacist panel because they tend to start at an average A1C. Our average A1C is about 9.8 at time of referral. But we measure A1C from time of referral to the time that we last manage the patient or discharge them from our service and return them to standard of care. And so that has been a very effective measure for us. Similarly, change in blood pressure, and we do we're starting to do more and more heart failure management and heart failure guideline directed medication therapy. So tracking how many times we're able to get patients on full GDMT, which has major ramifications for readmission reductions and patient mortality improvement, obviously. So those are key measures that we track. And financially, as we mentioned, star ratings, our impact. So looking at the quality measures that we have impacted throughout the year and then putting a dollar value, a financial assessment behind that. As far as how much return on investment and quality contract incentives and payments there are, has been really, really important. And we do generate revenue in our hospital outpatient department centers where we bill currently. So there is that component. And then with the increase in heart failure management that we're doing, we are hoping to track that patient population and reassess hopefully their reduction in readmissions and tie that to dollar values as well. The star ratings, I would say, have been overarchingly for our value-based programs in Dean and Fond du Lac. They have been really what justifies all of our pharmacist positions. We have very large contracts, and so without giving exact specifics, we've been able to be 5-star rated, 4 and 5-star in all our pharmacy measures for Dean Health Plan, for example, for over 8 years now, the 8 years that our pharmacy team has been involved in that, and that has more than paid for our program services.
Wow, what an impact. Thanks for sharing, Drea. We do appreciate that. Francesca, could you give us an overview of the quality measures that you're tracking at the Progressive Community Health Centers?
Yes, so like Drea, we also track a number of clinical, financial, and operational. Because we're an FQHC, we of course track the UDS measures because we have a significant population of Medicaid and Medicare. We're looking at our Medicare star ratings, our Medicare MIPS, the Medicaid core measures, and then we have a couple quality contracts as well as an ACO that we track through. During different seasons of our pharmacist services development under different quality managers, we've looked at the number of patients who get to goal within 6 months on the pharmacist service. We've compared the pharmacist patient panel to how they do if they're just seeing PCPs, to how they do if they get referred out to endocrine. And so all those different clinical measures have helped to support the services we provide. For financial, we are in a unique situation. We've not been billing. I always tell my residents, our leadership might be the exception, not the rule in some cases, but we've had really strong leadership buy-in that understands and values the quality we provide. And so we don't have a ton of financial requirements. We're encouraged to build through outcomes MTM when we can, if it's helpful to the patient, and something that aligns with our service. We are anticipating billing Medicaid, and we will likely have a goal related to billable encounters. But what I've seen with some other goals is they'll probably just be baseline benchmarkers. I'm hoping that as we do start to bill, that will give us more revenue to be able to hire additional pharmacists, but not necessarily give us that same number of, you need to see this many patients per day to generate this number of revenue like some providers do, just because our leadership really does value quality. And then operationally, we do have a visit goal each year determined by leadership, which we always knock out of the park. It's even with a high no-show rate in our population, it's very doable, and it's more so related to access. And then our goal is to try to expand those pharmacist services each year with our scope of practice, and then continue to advocate for additional pharmacist FTE. Now that we'll have a full-time pharmacist and then 2 pharmacists just there 1 day a week, and then a resident there 2 days a week. Now that we have a little bit more manpower, I think going forward, we'll aim to figure out, what is an appropriate ratio of pharmacists per primary care provider or per number of patients at the clinic.
Francesca, thank you so much for sharing your experience with the importance of clinical quality and quality improvement measures that are being tracked within your organization. Okay, next up, Nicole, could you share some ambulatory pharmacist metrics that you're tracking from ThedaCare?
Yeah, absolutely. First off, if you're not tired just listening to my colleagues on what we're all tracking, you should be at this point. It's always somewhat oddly reassuring that, if I feel like I'm tracking too much, I guess that's just the norm, because we have challenges in terms of there is no black and white direct one-to-one measure that's going to justify it in entirety. So we as well have many things. And if you haven't yet been inspired to consider how you can use provider status to your advantage, then let me try one more time, because there really are a lot of opportunities to make your case, and simply spin the wheel, look at the opportunities, and figure out what matches for you, so that you can really take advantage of the fantastic legislative changes that we've had in Wisconsin. All right, so let's talk about what we look at. Similarly, we look at volume. In other words, we do have targets for appointments per day, but that's really more so to maintain, to ensure that we are filling available slots versus again, trying to mimic, not necessarily what a provider would do. We do look at patient panels. We look at referrals, and that gives us an idea of the trend. In other words, what is the demand? Is it changing? We do bill for services. We bill 99211, and super excited, another mention again, that we will be able to expand that billing soon. We do bill for CGM, and we bill for MTM. We provide CMM, meaning comprehensive medication management services, billing the MTM code with one insurance provider, and that is with Health Partners. This is distinct from a CMR because it is not a one and done, and it is also time-based. So we have a great partnership with Health Partners. Of course, we look at the impact, the earnings that we can benefit from through our ACO contracts and those pharmacy measures again. As I mentioned, we have savings that we are able to enjoy through our focus on employee health. So we look at employee appointments and the 340B capture. Clinically, we look at A1C reduction. We also do academic detailing visits, which I'll describe very briefly, but an academic detailing visit is in essence a one-on-one individualized conversation between a member of my team and a provider, where we deliver key messages related to prescribing practices, evidence-based medicine updates, those types of things. And that is our way of connecting, building relationships, establishing the rapport, and building our clinical knowledge in that partnership. And we do look at heart failure guideline-directed medical therapy achievement and reductions and readmissions as well. So a lot of stuff that we are also tracking.
That's definitely a lot to have to track, but also very important, makes a huge impact on your organization and also on the quality of patient care that you're providing. Thank you, Nicole. As you can see, there are some similarities and differences between the metrics that are being measured among the 3 different ambulatory clinic settings that we heard about in this presentation today. For our 4th and final learning assessment question, what metrics are important to measure in the ambulatory care pharmacy setting? A, A1C reduction, B, volume of patient visits, C, star ratings, or D, all of the above? The correct answer is D, all of the above. As an overview, your A1C reduction, all of these are being measured regularly, and essentially your A1C reduction is your clinical measure, your clinical metric to show your impact on improving quality of care. Your volume of patient visits, that's going to be your operational metric to measure the volume and labor productivity. And finally, your star ratings, your revenue, that's going to be your financial measure to demonstrate your ability to financially support part or all of your program, including indirect and cost avoidance. Before we conclude our session today, we would like to share one last short video clip of different frontline ambulatory clinic pharmacists throughout Wisconsin that highlight the impact they're making in ambulatory care pharmacy.
I'm impacting ambulatory care by bringing a positive attitude and a lot of energy and helping to advocate for pharmacy and the pharmacy practice in order to bring about better change and help our patients meet their health goals.
The work I do as an ambulatory pharmacist at Theta Care helps patients reach their goals faster since I can see them multiple times in between their visits with their PCP. Through meaningful conversation, I address patient barriers and empower them to improve their health. We discuss the pros and cons of the various medications and options that they have, and ultimately they are the one that makes the final decision of which direction we proceed in.
By working with my patients and kind of building that rapport and trust with them in the clinic, I think I'm really showing them the value of having a pharmacist on their care team. And then that also allows them to kind of go out into the community and seek the help and assistance of pharmacists regarding some of their other disease states and working to kind of help with their other medications, lifestyle changes, things like that.
Members of our team are involved in initiatives at the health system level, such as our chronic opioid therapy work group and our system diabetes work group, in addition to our direct patient care responsibilities and our quality work. We precept students. We serve as mentors to other new ambulatory care pharmacists in our health system, and many of us are active members of PSW. Relative to the number of inpatient and community pharmacists across our organization, we're a fairly small team. So making sure that ambulatory care pharmacists have a seat at the table at the system and the regional level is really important.
In conclusion, there are a number of clinical, financial, and operational metrics that are used in different ambulatory clinic settings. Our panelist speakers shared the metrics they use within their organizations and clinic settings. It's important to know that each clinic setting uses different metrics according to their clinic needs, patient population, and incentives to help demonstrate the value of pharmacist services. Utilizing quality metrics is going to be a vital component to demonstrate the value of pharmacist services as we move forward with implementation of provider status. As we prepare for provider status, we would like to acknowledge that this presentation complements the Getting Prepared to Implement Provider Status webinar being offered by Nicole Green within the PSW Provider Status webinar series. On behalf of PSW and the PSW Ambulatory Care Advisory Committee, we would like to thank each of our panelist speakers for sharing their expertise in ambulatory pharmacy quality measures today. Thank you. For those obtaining continuing education credit, please use this CE code on the slide.